Okay, the next discussion is on the actual agents. I'm going to go into specifics about what the agents can do, how they actually work, okay? So how they actually deliver them, how they're absorbed, how do you do a good induction, and then we'll talk about a little bit about the individual properties in inhalational anesthetics. That I want to get into today, at least to get into the properties of it, so you can start memorizing, because this stuff, some of this requires memorization on your part. You can think about, for me it's easy because guess what? I've been using the agents a long time, so to me it's just sort of natural to think of these drugs. But to you, these agents don't really, you've never used them yet. So you sort of have to memorize some of these concepts for these agents. Now, how do you actually deliver the gas? I mean, you're going to reach soon a machine, you're going to go like, wow, look at this thing. It looks like a spacecraft, right? How do I actually use it to deliver an agent? Okay? And it's actually a pretty simple device if you want to keep it in your mind simple. And what you need first is that you need to carry the gas with some of the gas. And the gases that we use as carriers can be oxygen, air, or nitrous oxide. Those are your essential carriers. Those come in from piped in from the actual reservoir in the hospital. They come down the pipes, okay, and they go hook up to the back of your machine. Or you can turn on the gas via the tanks that are attached to the machine. Either one. Then they come through the flow meters. And when they come to the flow meters, then you put it at workable flows. You're no longer using it as pressure. If you're using a tank pressure for oxygen, it's about 2,000 psi to 2,200 psi pressure. That's pretty high. I mean, if you put that on somebody's face, it literally go, cheeks would blow up. I mean, nothing good would happen to it. So you can't really give that to somebody. Instead, you drop it down to what's called liters per minute. That's what you're delivering it as. Okay, so the flow meters change it from a pressurized system. It's still pressurized, but it drops it down to something workable that you can deliver in minutes of flow. Okay? If I give you 3 liters per minute of flow of gases, and I'm taking in 3 liters per minute of gas, then that keeps the circuit going constantly. Okay? The person will rebreathe part of this gas, but not much. If I go down to 1 liter per minute inspired, then that 2 exhale, 3 that goes out, 2 will be rebreathed. So now that's saving me gas. Okay? Now, the oxygen, nitrous, and air that act as carriers then travel towards the vaporizer. So the vaporizer at this point has been added on. It's going through now a tube. Whatever I put the concentration of these 3 guys together, that's what I'm actually getting to the tube right before the vaporizer. So if I put it 4 liters per minute of nitrous oxide and 4 minutes of oxygen, what's the percentage of nitrous oxide? 50%. Okay, 50%. It's just a ratio. So, but that means when it hits the vaporizer is going to be exposed to 50% nitrous and 50% oxygen. And you're changing that all the time. Does it really affect the solubility of the gas that you're talking about? The answer is no, not significantly. Okay, not to be clinically important. So you just have to understand that whatever you're dialing it, it's going to pass it through the vaporizer. The vaporizer then, depending on how you open it, the more you open it, the more gas goes down, and the more percentage-wise that it comes out. Okay? Now, the gas flows can actually alter the number of particles that you deliver. The more rapid the flow, in other words, the more liters per minute that I'm delivering, the more particles are going to hit you per second. So that person is going to go to sleep more quickly when I'm using things like nitrous oxide and stuff. Okay? It also is going to determine the onset of action because there's dead space. The distance between the vaporizers all the way through the circuit to the patient is all dead space. That's all distance that the gas has to be pushed along. So if I go to high flow rates, the gas gets down to the end of the tube, so that it gets into the patient more rapidly. So it makes sense when you put somebody to sleep to have high gas flow rates initially. Okay? And the other thing that's important is the gas flow rates can also alter the elimination of the inhalational agent. If I allow the actual flow rates to be really low, the person will rebreathe and will stay asleep. If, on the other hand, if I go twice the normal minute of ventilation that that individual is having, then I pretty much assure that you have zero rebreathing. And that's actually useful sometimes if your CO2 is exhausted. Let's say you have a patient with a malignant hypothermia and CO2 just is being consumed. You can double your flow rates of oxygen, and that will help eliminate the CO2 because the person won't rebreathe it anymore. Okay, it won't come back to the bare line. So now, how does the vaporizer work? The vaporizers that we use are called variable bypass systems, okay, which means that we can actually change the percentage of air or the mix that you're putting here, air-nitrous mix, that goes into the vaporizer. Once the concentration gets into the vaporizer, it goes to 100% concentration. So what does that mean? Okay, let me give you an example. Let's say we have a situation where we want to deliver 1% of halothane. Okay? So I turn my dial at 1%. If I'm running 10 liters per minute through the vaporizer, okay, 1% of that 10 liters is going to actually go into the vaporizer system. When it comes back out, it's on 100% concentration, but when it comes to the other end, it dilutes itself back to 1%. That's how it works. That's what's called variable bypass. Okay, so it depends on the agent that you're using. When off, the flow vaporizer bypasses the vaporizer completely. So when you turn this thing off, this triangle moves all the way down and closes itself off and seals it. So now the gas flows over the top of it, going to the patient with no vaporized gas. It's only when you click it open that this opens up and allows the gas to come through. Okay? And then they remix at the end. Now, this is a more modern looking, this is a simplified version. This one I'm trying to show you exactly what the variable bypass vaporizers can do. They're very much agent specific. So they're designed for the individual agent that you're using. If you're using desferrine and you put it in this kind of chamber, you'll kill the patient. You cannot use desferrine into these vaporizers. The person will not survive the event. Okay? The good thing about desferrine is that you can't really mix it in these because it doesn't allow you to. Okay? But they had to do that so that wouldn't happen. Somebody would screw up eventually. So it's agent specific. It's got temperature compensators added to it, and the vapor concentration is based on your dial setting, which is kind of easy to use. I mean, the other ways that we used to have to do it was we had a copper kettle. In copper kettle, you had to have a sliding graph to tell you what flow rates you had to deliver to the concentration that you wanted to have. It was really tricky. Okay? And if you change your flow rates all of a sudden, you would change your concentration that you were delivering. Versus nowadays, if you increase your flow rates, the concentration is still going to be the same. But you're going to waste more gas. Okay? If I increase the number of velocity of gas flow over the vaporizer and I double it or triple it, then I'm going to use a triple amount of gas than I would normally use. Okay? But it's not going to change my concentration. In the old days, when you did that, your concentration would either go up or down based on the solubility of the agent. That doesn't happen anymore, which is kind of a good thing. This is to show you that the gas is coming in. A certain percentage of it goes downwards, and it gets into the vaporizing unit where it becomes fully saturated, and then it comes back up, remixes, and it gives you your final concentration of agent that you want. Now, the way this thing is split, or how this splitting ratio takes place, is dependent on the agent. Okay? The splitting ratio is vaporizer dependent. Okay? If you're looking at halothane, your splitting ratio is 46 to 1, versus isoflurane is 44 to 1. If you took that halothane and isoflurane, mixed them up together, the effect would be almost unnoticeable. It wouldn't be a big deal. Okay? But if you look at enflurane and sevoflurane, those numbers are really different. Okay? And if you switch out these agents, you're going to have a problem. Okay? If you place the different agents when they're delivered, they'll be dependent on that splitting ratio that vaporizer is set for. If you put a high splitting gas into a lower one, you will give a greater percentage delivered. and that could be devastating. So if you were to put in halothane and accidentally put it in enflurane or in a sevoflurane vaporizer, you would deliver a significantly higher percentage than you're dialed for. On the other hand, if you place a low splitting gas into a high one, the person may most likely wake up because the actual delivered is much less. And so this is sometimes asked, and so you just in case you know. That's why you have to be very, very careful when you fill the vaporizers that you fill the right agent in the right vaporizer. You can't take one vaporizer and change it out and then just change the agents in it. It won't work. You'll get bad effects. This is the Tech 6 vaporizer. That's when we use the desflurane. A Tech 6 vaporizer has to boil the agent to keep it into gas. Okay, when you have a gas like desflurane that is very vaporizable, one of the issues with it begins to cool the liquid. Okay, as you pull it away, because it's pulling it away so fast, it cools the liquid, and then what happens to the concentration of it going into gas? It goes down. So it becomes unpredictable. So what they did with the Tech 6 is they actually heat it. When you actually put your hand on the Tech 6, it's a hand warmer. So when you're really cold in the operating room, just take your hand and put it on the Tech 6 and go, it feels so good, you know. So that's how you remember that it's exothermic. It's actually producing heat into it, okay? But if you put a desflurane into a variable bypass, you will kill the patient. You will get too high a concentration. You'll get almost 36% desflurane given to the patient in one blow, and that's not good. They won't do well with that. And now, if you look at the gas circuit, this will come more clear as time goes by, but this is a typical anesthesia gas circuit. Down here is where the anesthesia machine is at. Okay, so this is the machine giving you the gas flow rates, and this is where you give your volatile anesthetic. Okay, and then the gas comes in to the patient, goes down to the patient, and then when the person exhales, in a low flow, the gas is coming back. And then if you're in a low flow state where your gas flows are not going very high, you're not over minute ventilation, then the person, as it gets to the past the expiratory valve, then it goes partially to the bag, but also part of it will take place and allow the person to rebreathe. And if you really put it at really, really low flow states, the gas almost 100% comes back. So that person stays asleep with agents that they already breathed off. That really saves you money. Okay, because you can save on giving less anesthetic because you're rebreathing the gas that came out. And that's good for... What's that? You would, but what's here? That's your CO2 absorber. That's what eliminates the CO2. Okay? If you didn't have the CO2 absorber, then you wouldn't want the person to rebreathe at all. And you'd have to try to increase your flow rates to double the minute ventilation to assure that that didn't take place. But that's usually very wasteful gas, and that means you're taking all the anesthetic gas, you're not rebreathing any of it, it's all going out the scavenger. Okay? But that's why we have the barrel line. Does that make sense now? This is what we call the circle system because it's a giant circle. Right? Now, watch this very carefully here. You have two double arrows. This is your fresh gas flow. This has no valve in it, so gas can go both directions. The reason in a low flow system it doesn't go backwards this way is because this is barely enough to be taking up for the patient is sucking. If he's pulling 3 liters per minute, he's going to suck 3 liters a minute out of this circuit per minute. So as long as you're not over that value, that person's going to try to pull everything that you're delivering through that inspiratory valve towards him. Does that make sense? Okay. So now this person rebreathes. Now, the rebreathing, the anesthetic concentration can increase by returning gas back to the circuit. Allows that low flow rebreathing is significant, which helps maintenance and decreases your gas wastage. And at high flows, rebreathing is really not a factor because at high flows, the person is now not going to rebreathe any of the gas. The reason high flows are useful is that it increases particle numbers to the alveoli. So if I'm trying to get induction to take place, I want to go to high flows. I want the gas to get in there quickly because all that dead space, all that's going to get pushed in and get there quickly. High flows during the maintenance phase doesn't make sense It's just wasting gas. So in the maintenance phase, when I know I have the right concentration at the alveoli, then I drop my flow rates to low flow rates. And then if I want a person to wake up at the end, what do I do again? Now I want to clean the circuit and remove all the gas. Then I'm going to go back to high flows again. Okay? Now, by knowing that, though, you can play the game. You can actually play the game of emergence. You can change the velocity of how fast that person's going to wake up. If halfway through the emergence, the surgeon says, well, I got to put one more stitch here, I forgot about it, you can actually keep that person asleep without not dialing your anesthetic back on. All you got to do is just take your flow rates, go from 10 liters per minute, go back down to 1 liter per minute or less, usually 500 cc's per minute of oxygen. And what that'll do is that person will rebreathe all the gas that they're exhaling, and the concentration will actually rise and stabilize, and that person will stay asleep until you're ready to remove it. And now you've saved money because you haven't opened the gas again. And you also saved yourself time because now you're not reintroduce the anesthetic gas back into the agent, which then the body has to get rid of again. Okay. So let's see what happens if you're in a high gas flow rate on emergence. When you have that person spontaneously breathing at the end and you want them to get that gas off, this is what you do. You go to 10 liters per minute, and now the gas is coming in pretty fast. Okay, but part of it goes forward. If I'm pulling 3 liters per minute, only 3 liters of the gas is going forward, and 7 liters is going to go backwards. It's simple math. I mean, it only needs 3 liters to keep the system moving. So if I don't use it, then the other 7 liters is going to go somewhere else. And it's going to find the area of least resistance, which is going backwards. As it goes backwards, okay, it goes back to the bear line. So it's going to act like a huge dam. All this gas that I exhale is going to go forward, and it's not going to come through the barrel line. Instead, it's going to go all out the bag, and then it's going to go out the scavenger system. So this person will not rebreathe the gas, and also will not rebreathe CO2. So this person will start waking up very, very fast. The gradient will be established where the inspired concentration goes to 0 very quickly, which is what you want, because that means that's the alveolar concentration is 0. Whatever the blood is, now it's going to pour out. It's going to speed my emergence. Okay? You see, you won't get any rebreathing. Okay? On induction of anesthesia, at the beginning of the case, you maintain high flow rates to get anesthetic depth. Several reasons why is the second gas will also be helpful. We use nitrous oxide all the time when we're putting kids to sleep. I personally don't really like going above 50% on nitrous oxide in the kid. 2 reasons why I don't like them becoming hypoxic. And the other reason is because at 70% you get hyperagitation with nitrous oxide. So I'm not a real fan. I usually just go to 50% nitrous oxide and I use it to that point. That's plenty enough to get my second gas effect anyways. The vaporizer, please don't overpressurize unless you're trying to, doing it for a reason. Just set the dial to the MAC that you want, and then it gets you there. If you want to overpressurize, that's appropriate, but keep your hand on the dial. That way you know that you're not going to walk away and kill the patient. Okay, because you will hurt somebody if you're not careful. Okay? I actually showed overpressurization to somebody yesterday in an open heart suite. They were just coming off bypass, and the patient's blood pressure started creeping up, and I showed them how to use overpressurization. And we got the gas values up very quickly in less than a minute, and the person's blood pressure came down where it should have been, so they could pull out the aortic cannula. So you can use overpressurization for a benefit, but you can overdo it and get yourself into trouble real easily. Okay? After 15 minutes, you kind of cut back on your flow rate to low flow rate, because what happens around 15 minutes? Your FA-FI curve is now touching for most of the agents. So there's no reason to keep that agent on high flows at that point. You've got it saturated. So at that point, you can start cutting back on your flow rates. Okay? If you listen to Dr. Cook, he'll talk to you about time units for that as well, which is fine. That's another way of doing it. I just keep it simple. About 15 minutes, I cut it off. Or I look at my FA-FI curve on my anesthesia machine, and it'll tell me that I've hit plateau. At that point, then I drop the flow rates down. At that point, there's not going to be much change. Okay, so going to low flow makes sense at that point. You need to give at least 250 cc's per minute of oxygen. Okay, because when you're awake, your oxygen consumption rate is 250 cc's per minute. Now, is that the same consumption rate that you have under anesthesia? No, the consumption rate under anesthesia is 150 cc's per minute. So it's a lot less, but I want to have a safety factor. And I want to usually give my double safety factor. So minimum I go down to is 500 cc's per minute of oxygen at the minimum. Okay, I'm still not I haven't been sold on this completely. I'm reading about more on low flow anesthesia and playing with new things because I'm kind of getting excited about something that's coming down the pike, which I'll show you later on. So, excuse me. Sorry. If you see that you're if you're being told that you need to be using ephedrine in every case, that means you're overdosing the heck out of somebody. And the most likely reason that's happening to you is you're setting your dial up too high. You're setting your dial up to above 1 Mac, usually. If you're using straight just a volatile agent, then you're going to have to go to the full Mac value, which is going to suppress the cardiac system even more. So that's why I usually combine it with nitrous oxide so I can reach my 1 Mac value a little bit more without really have this profound hypotension that you get with just using the volatile agents. The absorption, you need normal ventilatory function is essential, so you want to limit your dead space ventilation. So if you're just ventilating fast, just puppy breaths, that's going to give you mostly dead space and the person's not really going to go to sleep. That's what you see with desferrine. Desferrine can really get you in trouble. When desferrine, if you get into light anesthesia and you're in the middle of the induction and all of a sudden the person starts not breathing and then you get into bronchospasm and then you try to deepen them with the volatile, with the desferrine, there's so much bronchospasm that you end up just doing puppy breaths. And the puppy breaths are just moving the gas inside the dead space. So what happens to your alveolar gas concentration? It's not doing anything. And desferrine is so insoluble that it just comes out of the system too quickly. Okay? And then you don't have enough concentration to keep that person asleep. It's a real problem. What you want to look at is you look at the inspired fraction, and the brain fraction is best represented by the expired fraction, which is what I told you the last hour. So what you want to do is when you're doing monitoring of your volatile anesthetic gas concentrations, you want to use the expired to really tell you your depth. Now, what actually depends on the actual absorption rate will be the concentration gradient. The greater the concentration gradient, the better the faster the induction is going to be. So that depends on your anesthetic delivery. That's why you can really get yourself into trouble. If you overpressurize, you're basically now depend on the concentration effect. So you're really like doubling, tripling the amount of gas that you're delivering at the alveoli. The downside to it is you can get so much faster in induction that you can get severe, profound hypotension very quickly in individuals. Ultimately, it depends on the number of molecules reaching the alveoli, and the second gas effect is important prior to equilibration. Once equilibration takes place, second gas effect is no longer important. So the only time second gas effect is important is on emergence and in induction. During the maintenance phase, second gas effect is insignificant. To think always about the surface area of the lung. If I have a one-side collapsed lung, what's going to happen to my that person going to sleep? Decrease the surface area downs. Very good. If I get a person with sickness, they get pulmonary edema or something like that, then it's going to be also going to diminish. And then you have solubility, the agents between highly soluble and low solubility agents. The lower the solubility of the agent, the faster the onset tends to be. The second gas effect is nitrous oxide. It helps, equilibration is rapid. During the early phase, the nitrous oxide leaves the alveoli rapidly, leading to a concentration effect with the residual gas being left behind, so it concentrates that gas. The decreased alveolar volume leads to an increase in percentage of the volatile gas. That increases the concentration at the alveolar level, which then causes a concentration effect, which then increases your induction velocity. If you look at your solubility, the high solubility inhalational agents need high flow to deliver them quickly. You get more depletion of the anesthetic gas due to greater uptake, and they do have a greater volume distribution, which delays your equilibration. On the other hand, the low solubility inhalational agents have low flow, anesthesia is susceptible. They're less depleted due to uptake, and there's lower volume distribution of these agents. So we thought if initially the desferrine was going to be a great agent, which it is. I mean, the limitation of it is it's pungent. And most people can't tolerate it. They bronchospasm and do some bad things. So for that reason, even though it has a very low solubility and you expect the person to have a rapid induction, it doesn't work out that way if you're having bronchospasm. So one effect can offset the other effect. If you look at the physical properties and chemical properties of inhaled anesthetics, you can see their vapor pressure is kind of important. Okay, you can see the vapor pressure for desferrine is really high at 669. That means that when you pour the liquid on the floor, desferrine almost immediately vaporizes. Okay, and that's particularly dangerous. If you drop a bottle of desferrine, you better leave the room as quickly as you can. I had one of my buddies in residency that dropped the desferrine bottle and then decided that he was going to pick it up by putting blue towels on it and absorb it. Well, fairly soon I get a call, say, hey, you got your buddy's in the room, and he's unconscious, face down on the floor. Okay, and I got in the room and I started getting dizzy. I grabbed his leg and pulled him out. Okay, and they had to get a hazmat team in the room to clear it. Okay, it was bad news. So you don't want to drop these bottles. They don't break very often, but he must have just dropped it right at the right angle and it just blew apart. So, but he found out real quick that it definitely can put you to sleep. Okay, he woke up about 10 minutes later. I was still dizzy for about half an hour too. So you don't want to be exposed to this stuff. So don't be picking this stuff up with blue towels. It's not really smart. And invariably, you know what one of you is going to do? You're going to fill up the vaporizer, and then you're not going to screw it down. So when you open up the vaporizer at 10 liters per flow rate, this stuff is going to come out like a water fountain. And it's going to vaporize all over the place. And you're going to feel real good in about 10 minutes afterwards. You're going to feel like, oh my God. And then you go home and you got a headache for the next 24 hours. Okay, so don't really do that if you can avoid it. Okay? The preservatives, the only one that has preservative is halothane, which is thymol, which is a problem. And then you have to look at it from stability point of view. The stability in soda lime for halothane is poor versus enflurane, isoflurane is actually good. Sevoflurane is also bad. So it can actually convert and cause toxic compounds to be produced when you expose it to this. And I'll show you that in a minute. And then you have your blood gas partition coefficients, which I think you should know, and your MAC values. Now, when you look at structurally at the volatile anesthetics, they look similar, somewhat. They have fluorinated compounds. Okay? So the new agents that we use have fluoride in it. It was not until after World War II that we actually developed fluorinated compounds. It was actually a byproduct of the production of the H-bomb. Okay? So without the H-bomb, you wouldn't have had fluorinated compounds. Fluorinated compounds are really dangerous to make. Okay? When I was a chemistry student, they had somebody who was playing with fluorinated compounds up in the University of Florida, and they blew up the whole lab, almost killing them in the process. Because if you drop fluorine in water, the true isolated compound fluorine, it's like a giant explosive. Lucky for him, he was playing with this stuff, and he noticed that the stuff was dropping out of the beaker, and he threw himself out the door when it blew up the whole lab. He survived the event, but I don't think he became a very good graduate student after that. I think they were kind of pissed. They lost the whole wing of the area off. So this stuff is actually fairly dangerous. Now, fluorine, once you bind it to carbon, it becomes almost impossible to break loose, which is kind of good. Okay? So for that reason, it's stable. What they did with halothane is they couldn't put enough fluoride molecules on it, so instead they added bromide and chlorine. The downside to it is that halothane is metabolized by breaking off the bromide. It's called bromination. The downside to it is bromide is very heavy. If you look at the molecular weight of halothane, it's actually very heavy. And you look at the actual number of fluorinations on halothane, it's only 3. As you add more fluoride, the agent becomes more insoluble. Okay? So when you add enflurane and isoflurane are isomers. They both have 5 fluoride compounds, but they're just slightly differently arranged. They have the same molecular weight, and they have essentially the same chemical nomenclature, but they have different placements. If you look at enflurane, okay, you have the hydrogen is flipped for the fluoride, and the chloride is flipped. Okay? But otherwise, they're essentially the same weight and very similar in a lot of ways, but they act completely different. Now, isoflurane is a much better agent than enflurane, as we'll show you a little later, for for many reasons, and it's simply due partly to the changes in their chemical formula. As for the desferrine actually has 6. Actually has 6 fluorinated compounds, which makes it very insoluble. Where it doesn't, when your solubility doesn't go down, is because you add a methylation group, and then they added, these are methyl groups that they added fluoride to. So now SIBO actually has 7 fluorides. I'm sorry, this is flipped. This should be up here. But this has 7 fluorides. So SIBO is drawn incorrectly in the book. The textbook only has it as 6. That's not true. SIBO is 7. That's how you remember it. That's why they came up with the word. SIBO for 7 fluorides. Hello? Why did they get it wrong in the book? I don't understand. Okay? And then nitrous oxide, which is NNO, connected up together. And that one you sort of should know the nomenclature, because I'm going to sort of draw it for you and make it screw it up. I'm going to put the oxygen in the middle and do something. So you sort of need to know what the structure looks like, I think, for that one. The effects of CO2 absorbers will be different in different agents. If you look at halothane, it will be broken down by a dry absorber forming carbon monoxide. So does isoflurane, so does enfurane, and desferrine really causes a huge amount of carbon monoxide formed if you have a dry absorber. But do you really ever get a dry absorber? They found out in North Collier the other day. Somebody decided to leave the oxygen flow rates going full blast overnight. Okay? And they actually had it closed off, so now they didn't close it off. They left the bag off the actual system. So they were running high flow rates of oxygen all night through an open system, so all the water that was in the barrel line left. Then they used desferrine. And everybody woke up with what after the case? Chest pain. Carbon monoxide poisoning, the way you pick it up is a person complains of chest pain afterwards. Okay? Now, not a lot of people know that for some reason. You know, when I finally heard about it, which was the next day, somebody said, "You got an alert here. We got a problem with them on the machines." I said, "It's easy. You got carbon monoxide poisoning. Did anybody draw blood gas?" No. Okay, so all you got to do is draw blood gas, and you would find out that person has carbon monoxide, and then you would have changed out the barrel line for that next case. That's all you had to do. The barrel line has become dried, and then when you expose the desferrine to it, you form a lot of carbon monoxide. It's that simple. Okay. If you look at when it's wet, nothing happens. It's perfectly okay. Okay. If you look at sevoflurane will form, even a wet absorber forms compound A. Now that's how the drug companies try to make sure that sevoflurane didn't come in this country. Sevoflurane was used in Japan for 12 years before it came over the United States. Okay. They didn't want the sevoflurane to come over the United States. So they said, well, compound A makes it an evil drug to use. Well, no, just change out the barrel line. Okay, change it to a different agent. And I'll show you in a minute that compound A is really not an issue anymore, as long as you use certain kinds of CO2 absorbers. Let's go through the different agents. And this is where I'm in. I need to cover this material, so I think I'm going to take a 10-minute break and then start up for another hour, so you guys can get exposure to these medications. Because I think if I don't do this now and I do it next week, then you're going to be stuck with memorizing a lot of stuff, okay, at the last minute. So I think you need the 2 weeks to sort of look this over. One of the things that I've been reading about is how to get people to learn material more. And the best way to do it is expose them to it over and over again. And do it in small blinks, not all. If you try to start memorizing this 2 days before the test, you're going to fail this test. You need to start memorizing this stuff now, and over again. Because you know what? When you get to clinical, I'm going to hammer you on this. Okay, I'm going to ask you every day, what's the blood gas partition coefficient for this agent? What's the MAC for this agent? What's the vapor pressure for this agent? Okay, what is the tissue blood partition for this drug? And why is that important? I will ask those questions to you all the time. And students get tired of it. It's like, I know that number. Okay, fine. Now you know it. Now you can tell me you know it. And I'll leave you alone. We'll go to another subject at that point. Okay. But it's one of the things that if you don't understand that, then you're basically giving a medication without knowing what it does. Okay. So we'll stop here. Give you. they'll start fighting you on the mask. And everybody thinks it's the SIBO that's causing it. It's not the SIBO, it's the 70% nitrous that's doing it. Okay, so because of that, just say at 50% nitrous, you're better off with it. Okay. It also, it's supportive of the autonomics, unless you have very bad cardiac output. But in normal circumstances, nitrous oxide really doesn't drop your blood pressure, and it doesn't really do bad things to the heart rate. I personally think that the nausea-vomiting controversy is still very unsettled. Okay, I'm not a real believer that nitrous oxide causes nausea and vomiting. Now, do I agree that the nausea goes up considerably when you go up to 70%? Yes. So if I use it clinically, most of the time I stick around 50%. Because then the nausea-vomiting rate is negligibly different. But do I use it every once in a while to go to 70% when it's appropriate? Yes, I do. But I still think is it absolutely the main cause of nausea? No, it's not. There's a lot of other things that also cause. Narcotics are big-time causes of nausea, vomiting. How many times have you seen somebody vomit from morphine? Okay, I mean, so do we stop using morphine for anesthesia or Dilaudid or whatever other narcotic? The answer is no. So, I mean, if you tell me that that's the only reason you're doing it is to limit it for nausea and vomiting, then I'm going to tell you, well, you know what, you shouldn't use any narcotic. You can't do that. What do you mean? Okay, so you got to look at everything in context, okay? Where it is contraindicated is if you have an enclosed airspace that you are worried about, like a small bowel obstruction, okay? The other place where it's in a problem is that it inactivates vitamin B12, so if somebody is B12 deficient, it can cause neurological damage as well as anemia to develop. So vitamin B12, anybody who's got megaloblastic anemia, you should not use nitrous oxide in that individual because they're vitamin B12 deficient. Okay. Where you also see vitamin B12 deficiency is in alcoholics. So how do you take care of it? Usually, the way I take care of it is I start a banana bag before I start the nitrous oxide. You know what a banana bag is? It's a multivitamin. You just put it into your bag and mix like a nice yellow bag of IV fluids. Just give that to the patient, and you don't have to worry about nitrous oxide giving you any problems. It won't have any effect. Okay. Where the only time you see that is you get the neurological damage from long-term use of nitrous oxide. It's people that actually will actually use nitrous oxide to inhale it. And when they do that, they actually will develop long-term neurological damage. They'll get peripheral neuropathies. I had a dentist come in a few years ago, and nobody knew what was going on with him, and they were taking him back to surgery because they said he had he had some kind of spinal stenosis, and that's why the reason that he was getting this problem. And as soon as I saw him walk in the room, he was walking like this, flat-footed, very strange walk. And I looked at him and I said to him, I says, that's pretty unusual. Usually for people that have spinal stenosis, they drag their foot. Okay, because the sciatic nerve gets knocked out. Okay, so it's unusual to be flat-footed. That's something else. There's no sensory information. What he's doing is he's walking like that because he can't feel his feet. Okay, so he's clomping his feet on the ground to hear them as they hit the ground so he knows where his feet are at. So he's got peripheral neuropathy. So I started talking to him for a little bit. I said, you got to be honest with me. Before we had this operation, it's a pretty big operation. Are you using nitrous oxide? Like a lot of it. Sort of hemmed and hawed for a while. I said, yeah, I actually do it every day. So that's what the problem was. It wasn't his back. He was getting toxic on nitrous oxide. He was developing the peripheral neuropathy from the nitrous oxide abuse. So the surgery was canceled, and off we went to do a different treatment modality, this guy, which is getting him to stop using the nitrous oxide. The people that get hooked on nitrous oxide in the highest percentages in the population are dentists. Okay? So that's where you have to put the job with the risk. You have to be careful not to insult, but at the same time you've got to sort of ask. The benefits of combining nitrous oxide and volatile anesthetics is significant. Okay? And I'm going to keep showing this over and over again so you sort of, when people argue that nitrous oxide has no benefit, I'm going to want you to argue back. I want you to say, look, why is it that nitrous anesthetics, when you combine it with a volatile anesthetic, it decreases the overall MAC total? So, and that's good because that means the anesthetic, which is an inhalational anesthetic, has some significant bad effects in the cardiovascular system, which we'll show you a little later on. The other thing to nitrous oxide is supportive ventilation. If I give nitrous oxide with the same gas, and I use it the same MAC value combined, the person that's giving nitrous oxide will have a lower end tidal CO2. So the person will breathe more efficiently when I combine it with nitrous oxide for the same MAC value. It's also supportive of cardiovascular stability. It's really stupid to shut off the nitrous oxide when somebody's blood pressure drops. That's not the agent you want to shut off. The agent you want to shut off is a volatile anesthetic. The reason that people shut off the nitrous oxide, and they don't understand, and the blood pressure rises, is what happens when I shut off the nitrous oxide if I don't change my volatile anesthetic? What did I just do? Nope. I decreased my MAC. So in other words, instead of being at 1 MAC, and I'm using 50% nitrous, and I combine that, I'm using a total of 1 MAC. When I shut off the nitrous, what happens to my MAC? My MAC goes down to 0.5. And then the blood pressure goes up. Ooh, it's the nitrous oxide. No, you just changed the MAC value. Okay, if you put the same MAC for fluorine back up to 1%, to 1.17% on your fluorine, that person's blood pressure would be in the toilet. Okay, so shutting off one agent to decrease the overall MAC doesn't make sense. Okay, and the reason the nitrous oxide works faster is because, guess what? It's more insoluble, so it comes off faster. So then you imagine that's what the drug is causing, but it's really not. Cardiac-wise, if you maintain the same MAC, nitrous is actually supportive of cardiovascular stability. Okay, unless you have somebody who's really sick in their heart, then you can affect cardiac motility, but that's usually only if somebody's sick, and you should know that ahead of time. The second gas effect is also something that helps you on induction to get the gases off in the patient. If you look at the volatile anesthetics, historically we had very soluble agents such as ether and chloroform. These were really very, very good anesthetics. They were. Their limitations were that they lasted too long and they blew up. That's a real problem. Okay? When you lose your whole anesthesia team, killing everybody in the room, including the nursing staff and the surgeon, most people kind of frown on that. Okay? So really, we've moved more to the fluorinated compounds simply so we don't kill medical personnel, okay, which is kind of good. The fluorinated compounds, as you fluorinate them more, you usually make them less soluble, more stable, not flammable. Unfortunately, they're more expensive. Okay? The more fluorination you add, the more expensive the product becomes. So sevoflurane is actually more expensive than desflurane to manufacture. Okay? Halothane was one of the first one that was made. It's a halogenated alkane. It's got a molecular weight that's actually pretty high for the small little molecule that it is. The reason it's so heavy is because of the bromide. The bromide is very heavy in molecular weight. I think it's like 134. So bromide's pretty heavy. The good thing about halothane is sweet. It tends to be not pungent. You can actually inhale it and not really, you can tolerate it without too much of a problem. If you use 50% nitrous with it, then people all universally tolerate it. We put kids to sleep in the old days was using halothane. Great agent to induce people with. And now we're using Sevo instead. It's a clear, non-flammable liquid. Almost all the fluorinated compounds are clear agents. They don't have any color to them. The vapor pressure is actually fairly low, which means that it tends to be pretty potent. Okay? The blood gas solubility, it is very soluble, which is intermediate solubility, which means that it still has a fairly rapid onset and recovery. The one that ether is much more soluble, so your onset is actually very slow and recovery is slow. My dad actually got ether. He still remembers that to this day. He couldn't believe that I was going to be an anesthesiologist. He thought I was going to be some kind of sadistic SOB. Because what they did in the old days is that they had 4 or 5 people in the room. They were orderlies when you did anesthesia. You know what the orderlies they were there for? To hold you down. Because it would take that long for the ether to kick in. You would go into what's called a hyperexcitatory state. And until the gas got in you, you had to struggle and hold the person down. Pretty dramatic. Versus the gases we use now, the person just holds a mask and the person goes to sleep. It's magical. It's great stuff. Sometimes you get hyperexcitability, but most of the time you don't. Okay? The potency is very high with the MAC value of 0.75. Halothane is an excellent amnestic. It's also very good with pain control, which means that when you shut it off, what happens to the pain levels? They go up. So what do you have to rescue them with? Narcotic. So as you shut off these agents, a lot of times you should titrate just a little bit of narcotic to make up for the difference of that agent is being displaced out of the lungs and out of the tissue. The areflexia is very significant, okay? Which means that if you give too much of halothane, the person will not breathe anymore and also will not move anymore either. Okay? If you're doing a twitch monitor, when you turn the halothane on, the twitch monitor would drop its twitches. So instead of having a normal train of 4, your train of 4 would drop by 50% with halothane. That's pretty impressive. That means you're actually knocking out a very big component of the muscle contractility, okay, the twitch height. So halothane is really not supportive of ventilation. It increases respiratory rate, but it does it by limiting tidal volume. So your total minute ventilation does what under volatile anesthesias like this? They fall. Okay? The good thing about it is that it's a very potent bronchodilator, which makes it a very useful agent, especially in asthmatics. The autonomics, it has some bad deleterious effects. That's why we're not using halothane anymore. It's not the magical drug because it does depress the cardiac calcium voltage channels. And it can cause significant decreases in cardiac contractility. So not only does the heart rate go up with this agent, but the stroke volume goes down. Okay? So you have double effects. So overall, you have a decreased cardiac output. It is a partial coronary vasodilator, and sometimes you'll see bradycardia and even nodal problems with it. But most of the time, you get tachycardia out of this agent. It increases myocardial sensitivity to epinephrine as well, which is usually a classic question. Which of the volatile anesthetics increase your sensitivity to epinephrine and causing you to increase your risk of dysrhythmia? And the answer is halothane. Okay? And your nausea and vomiting risk is increased. As soon as you open these agents, all the volatiles, I don't care which one you use, you're going to increase your risk of nausea or vomiting. Halothane centrally causes central cerebral vasodilation, increased cerebral blood flow, so it's not a good agent for somebody who has elevated intracranial pressures. It does blunt sometimes the cerebral vascular autoregulation. And if you give hyperventilation prior to starting the halothane, you can offset the effects of this. So sometimes you can affect it by the changes in CO2. Halothane, unfortunately, is toxic for some people. When halothane it gets into your bloodstream, it does get broken down. And you can actually measure bromine levels in people's bloodstreams after you give them halothane. Halothane, unfortunately, also on re-exposure, gets you an allergic reaction, or it's like an anaphylactoid-like reaction. Your body begins to react to some of these metabolic byproducts and forms antibodies to it. So the next time that you're exposed to this gas, the liver, when it binds to the halothane binds to the liver, the antibodies attack the liver, causing a hepatic necrosis of the liver, and you can die from that. So hepatotoxicity is a fairly big problem with halothane. We'll talk about this a little later on next week. You can also, to prevent decomposition, you have to add an amber bottle, which is a dark bottle, and you have to add a preservative called thymol into it. The thymol, when it dries out, it makes your vaporizer clog up, and then you don't have an effective vaporizer working. So that's one of the limitations with the halothane vaporizers as well. Halothane contraindications is MH. Everybody that has MH is contraindicated with all the volatile anesthetics. So you can hear that over and over again. You get liver dysfunction from previous halothane exposure. Intracranial mass lesions may also be a problem because it increases the ICP. Patients that are severely hypovolemic or have significant aortic stenosis, you really don't want to use halothane because it decreases the contractility, drops your diastolic pressure too dramatically, and you can get a complete loss of coronary perfusion. Where it's also a big problem is in pheochromocytoma. Why is it such a big deal with halothane? Right. It releases epinephrine. Okay? So it sensitizes the myocardium to go into a malignant dysrhythmia. And if you use halothane in the old days with pheochromocytoma together, you had a 90% mortality rate. That's pretty bad. With aminophylline, you can also go into severe ventricular arrhythmias because aminophylline is a very similar-like drug to epinephrine in certain ways. So because of that, you can't really use it together. Enflurane was an extra agent that came out of the market. I used this for about 3 to 4 years in my practice. It's almost not out there, but I just sort of want you to know a little bit about it. We used to call it our orange drug. If you look at halothane, it's our red drug. It's got a red band around it, so everybody called it the red drug. Okay? Then you had the gold color, or the orange medication, which is Enflurane. Enflurane is basically very similar to isoflurane. It is a clear, non-flammable liquid. It has a pungent odor, which doesn't allow it to be used really for induction agents. The vapor pressure is actually a little bit lower. It's on 175 millimeters of mercury. And the blood gas partition coefficient indicates to you that it has intermediate solubility. The MAC value is about 1.63, which is higher than isoflurane is, so it's less potent. The problem with Enflurane is that when you form a strong base, like a dry berylline with Enflurane, you get high amounts of carbon monoxide production. The normal berylline by weight has 15% water in it. So to dry it out completely is actually fairly difficult. Okay? The way you can actually dry out berylline very easily is leave the flow rates on oxygen all night, and then you got to do the second part. If you just did that, nothing would really bad happen. The second thing that has to happen is you have to take the bag off your circuit. If you do that, now the gas is going through the berylline and drying it out. Versus if you have the bag on the circuit, the bag gets the water vapor and it comes right back. So it stays wet. So you can dry it out, but you've got to screw up by doing two things at the same time. Enflurane is actually a fairly good agent for amnesia and analgesia. The areflexia has some significant effects. It also is not supportive ventilation. Autonomics is a negative cardiac inotrope, and it lowers cardiac output, arterial blood pressure, myocardial oxygen consumption. And heart rate usually increases with it, and the nausea vomiting rate increases. So why isn't Enflurane such a good? Why don't we use it then? What's so wrong with it? And this is what's wrong with it. Okay? Enflurane will cause seizure activity, or seizure-like activity. And the real danger of Enflurane is if you induce this seizure-like activity, the person becomes rigid on you, and you can't figure out what the heck's going on. You're actually inducing a seizure in that person's brain. And the danger of it is the cerebral metabolic rate of oxygen consumption goes skyrocketing upwards in these individuals. So in other words, you're depriving the oxygen of the brain, and you may get actually hypoxic damage to the brain. Very, very serious problem with this drug. It does also increase CSF production and increase cerebral blood flow and ICP. So it's contraindicated completely in anybody who has any kind of intracranial mass lesions or have the seizure disorder. Anything that's wrong with the brain, you can't use Enflurane. Okay? Pretty much for that reason alone, this drug has been taken off the market, or it's not very readily available. Okay? MH is contraindication, pre-existing kidney problems, seizure disorder, intracranial hypertension, and then also isoniazid enhances Enflurane defluorination, which causes an increased level of toxicity with it. Let's talk about the agents that we do use. Isoflurane is the first one. In some places, isoflurane is being almost removed. I like isoflurane. It's a great agent. It's very, very safe. It's also very cardiac stable, and it's also cardiac protective. It's a halogenated methyl ethyl ether. You can see right here that it's got the chloride molecule here, and it's got the fluorides out on the outside, which makes it a lot less metabolism takes place. It sort of helps prevent it, protect it. It's a clear, non-flammable liquid with a blood gas partition coefficient of 1.69, and the MAC value on this is 1.15, so it's a little more potent. It is an isomer of Enflurane. It's actually more complex to manufacture than Enflurane, and as a consequence, it's more expensive. But it has extreme physical stability. Okay? You don't have to have any preservatives, and you don't have any detectable deterioration for 5 years of shelf life. That's a great agent. Okay? You don't have to worry about the stuff breaking down. When you add a strong base to isoflurane, you still form carbon monoxide production, so you can that'll be a problem when you're using dry berylline. Isoflurane is an excellent amnestic. It's also very good at pain control. It has also significant muscle relaxation properties. It's a potent bronchodilator. It's not supportive of ventilation, though, of course, because it is suppressing the diaphragmatic function. So you have an increased respiratory rate and an overall decreased tidal volume that's more so. And as a consequence, your minute ventilation falls when you give isoflurane. Autonomic-wise, it's kind of helpful. Autonomic, it does minimal cardiac depression, so it doesn't really affect contractility very much. The carotid barrier receptors stay relatively intact, which means that heart rate increases as blood pressure falls in these individuals. You do have some mild beta-adrenergic stimulation, which means that heart rate does go up. It dilates the coronary arteries, but several large studies failed to show convincing evidence of clinically significant coronary arterial syndrome. We were told in the 1980s, 90s, when I was practicing, that you should never use fluorine for open heart surgery because of the coronary steal phenomena. That was proved to be so false and so wrong that eventually now every cardiac anesthetic is using isoflurane, and now they're using desflurane as well. So, things change over time. The coronary steal thing was actually a theoretical concern. I'll show you a little drawing about that a little later on at the next time we talk about it. But it's been pretty much disproved. Nausea, vomiting is, again, increased with these agents. We're central nervous system. If you exceed 1 MAC, you can increase cerebral blood flow in ICP. So if you have somebody with intracranial mass lesion, you're not going to increase the MAC to above 1. You're going to stay below 1. This can be offset by hyperventilation. So if it also decreases your cerebral metabolic rate of oxygen consumption, which is what you want. You want the brain to shut down, not use oxygen. You want it to protect the brain. It also can, if you go to MAC of 2, you can flatten the EEG. You go isoelectric. So that means the brain is completely out, asleep. It's really the preferred inhalational agent in all the neuro cases that we use. Okay, so when you do your neurorotation, the agent you're going to open up is isoflurane. Okay, it's very reliable. Okay. The only thing that's contraindicated is it has malignant hyperthermia and severe hypovolemia. Then you got to ask yourself, why isn't isoflurane the magical drug that it sounds? And the answer is, it's a magical drug. It's a great drug. The problem is it is too soluble. And because of that, it takes a little bit longer to take off. But beyond that, it's really a great drug. That means you just got to shut it off earlier. Okay? Desflurane came down next. Desflurane has 6 fluorinated compounds to it. It's a fluorinated methyl ethyl ether. It's got a vapor pressure that's much higher than all the other agents of 681. Depending on which book you read, the number of values changes, which is fine. It decreases the potency significantly, so the MAC value is 6. The blood gas partition coefficient shows you that it's a low solubility agent. Actually, has a very low solubility of 0.43, which leads to rapid equilibration, rapid emergence. It's a clearly non-flammable liquid, but it is pungent, and the pungency is what causes problems. The pungency causes airway irritation, increased salivation, breath holding, coughing, and laryngospasm. Okay, when I was a resident, I was asked to be involved in research. This is one of the reasons I didn't stay in research, because everybody beat me up pretty badly after the study. We were told to put these kids to sleep with desflurane, this new wonderful agent that was supposed to work magically because of low solubility. I was sold on it. I read all the stuff, and I was like, this is great. It's going to be a great agent. Put the kid to sleep. The first kid that we put to sleep, the kid turned like blue, like my shirt. I was dying, okay? The saturation was 30%. The kid almost died on me, okay? And I had my attending with me. We're both freaking out. So, okay, fine. So the next time we did it, second kid, same thing happens. Okay? And we did it for 3 kids that day. At the end of the 3rd kid, I was pretty much wiped, okay? I was like shaking. My hands were like, I'm done. I can't do this anymore. So let's call these guys up. We called Dr. Eager up in California. He told us over the phone that we were a bunch of idiots, didn't know what we were doing, and said he'd fly out the next day and come and see what we were doing. Okay. So we all waited for the expert to get there. And I like Eager. He's a really good guy. He gets there and starts talking to me. He said, what have you been doing? I said, well, we did this induction. I'm used to using halothane. We did it 50%. We used the desflurane, and then the kid just stopped breathing about halfway into it. So I said, well, let me show you how to do it. And I asked him, so how many kids have you put to sleep? He looks at me, none. I said, oh, okay. So you haven't done any yet. He says, okay, well, we'll be all prepared with the succinylcholine. But we got smart by that point. We put IVs on everybody. Okay? So all these kids now got preoperative IVs, which, of course, they don't want to have it, but we did it for safety reasons. And we put this next kid to sleep, and he turned blue, blue, blue. Same problem again. Get him succinylcholine, ventilate him, get him out of it. So we're done. That terminated the study at that point. Okay, and that's when the report came out that desflurane can't be used in kids. So as you can see, my most likely likelihood of making it as an academic physician went downhill pretty quick. Okay, all the pharmaceutical reps went, "Geez, Nolan, you destroyed desferrine." It's like, I didn't want to do that, but that was one of the definite limitations of this drug. So that's when you hear this is really true. I mean, it's really serious. This can also happen on emergence. So I'm really leery of this drug. I'm very careful with anybody who has bad COPD. I sort of avoid it. Asthmatics seem to be not a problem too much with this drug. You would think that they would be, but they don't seem to be. It's really the smaller caliber airways, like in little kids, that you get in trouble with it. It's similar to isoflurane except for a substitution of chloride and fluoride right here. And the alpha ethyl component, that's what makes it different from desferrine, from isoflurane. It's complex to manufacture. It has extreme physical stability, and there's no preservative needed. And you also get no detectable deterioration for 5 years with desferrine as well. Desferrine is a great amnestic. It's a great pain control as well, and has significant areflexia. It doesn't, again, it has significant muscle relaxation. Is it as strong as the other agents? The answer is no, but it still gives you muscle relaxation. The autonomics is similar to isoflurane, but does not increase coronary arterial blood flow. So some people are actually using desferrine for cardiac cases. The problem with it is that you can only go to 1 Mac. That's a real limitation of desferrine. Really, if you go above 1 Mac, you start getting into trouble with this agent. You start getting severe tachycardia with this agent. So that's a real limitation. You do get an increase in nausea, vomiting. So if you change your dial really quickly too with this agent, you can get pronounced tachycardia and hypertension, which is a real limitation again. So if you're using a desferrine, it's okay to do, but you're really having to add a lot of narcotics. Desferrine for central-wise, it's a cerebral vasodilator, which increases cerebral blood flow in ICP, and so it's not recommended for anybody with central nervous system space-filling lesions. So it's not really a good neuro case. It does cause a marked decrease in cerebral metabolic rate of oxygen consumption, which can cause a compensatory vasoconstriction. So sometimes you can offset the effects, and then the EEG effects are similar to isoflurane. But still the limitation is you can't really go above 1 Mac because of the cardiac effects that you have with this agent. Desferrine also, when you combine it with strong bases, like the dibariline, you can produce high amounts of carbon monoxide. It's actually one of the worst ones to use. Carbon monoxide production with desferrine is very high with the dibariline. The normal, especially with barium hydroxide lime, but also sodium and potassium hydroxide will cause problems. On the other hand, if you have calcium hydroxide, it minimizes the degradation process. And the other one they're also finding out is lithium hydroxide. It has no breakdown. So malignant hypothermia susceptibility, yes. Hypovolemia may be a problem, and endocrinal hypertension makes it a contraindication, or at least a precautionary method of using this drug. So desferrine is not one of my friends in doing neuro cases. Then we'll talk about SIBO, and then we'll stop after this. Sevoflurane, I think we have one more agent to talk about. Well, I'm going to run out of time. I'm going to do sevoflurane, and then I'm done. And then we'll talk about xenon next week, which is something you're not going to be exposed to too much yet. Sevoflurane is an excellent amnestic. Did I miss a slide? Yeah. Sevo is a fluorinated methyl isopropyl ether. You can see over here that it's got CF3s out here, that's 6, and then you got another fluorinated compound here, making a total of 7. That's why it's called SIBO, for 7. Vapor pressure is actually fairly low at 160 millimeters of mercury. And it's non-pungent. That's what makes this agent very helpful. It's our yellow drug. Sometimes we used to call, when we used to take care of kids, isoflurane is a Barney drug. It's just purple. Okay? So you'll hear me say that once in a while. I said, turn the Barney agent on. This one's yellow. Okay, so this is our yellow for the yellow streak in people that don't want to use it. They're worried about compound A. That's how I remember it. Vapor pressure of 160 millimeters of mercury, non-pungent. That's what makes it kind of useful for doing inductions. It doesn't cause bronchoconstriction. In other words, it does cause nice bronchodilation. It has the least degree of airway irritation of all the volatile anesthetics that we have. It's a great induction agent. The blood gas partition coefficient makes it insoluble at 0.69, which means it has low solubility, which makes it a rapid onset, rapid emergence if you use it less than an hour. The big problem with this is the emergence is so fast, just like desferrine, that you can get emergent delirium with this drug much more than others. SIBO specifically is very high in risk of coming out of it with emergent delirium, especially when you use it with kids, because we use it with kids a lot because we're doing what? We're putting them to sleep with it. We're not using desferrine to put the kids to sleep with. So we're going to use this agent. The problem with this agent is when you come off too fast, and the kids wake up, really wild and crazy. And it's almost in the literature that they keep telling you, you cannot give narcotics to little kids. And some people really believe that. The reason they believe that is because they used halothane. Halothane's a great agent because it stays on forever. So when you shut it off, when you take the kid to recovery room, all the recovery room nurses are experts in using narcotics. As soon as the kid gets there, they're already hitting the narcotic to the kid's IV. But you're afraid to give it in the operating room. That doesn't make sense. Okay? But now what's happening is the sevoflurane wakes up so fast that you better give the narcotic in the operating room, because by the time you hit recovery room, the kid's going to be absolutely crazy. Okay, so you've got to change your practice simply because of the solubility of the agent being slightly different. Okay? MAC of 2.0 is the actual MAC that we use. It's 1.8 on some of the books, which is fine. Anywhere between 1.8 to 2 MAC I can live with as being the MAC. I usually just use 2. It's just easier in my head. SIBO is an excellent anesthetic. It's also great for pain. Agriflexia is actually very potent, more so than desferrine. It's not quite. But if you look at the tissue-to-blood partition coefficient, it would indicate to you that it's more stronger than isoforine, but the difference is that it's very close to it, and isoforine is more potent, so you tend to see more of the areflexic actions with isoforine. It is not supportive ventilation, just like all the other agents, so it increases respiratory rate and decreases tidal volume. But it does give you significant muscle relaxation. The autonomics is a mild negative inotrope. It has little or no tachycardia. It causes bradycardia, or decreases heart rate when you use it initially to hit 1 MAC. Once you go above 1 MAC on SIBO, then the heart rate begins to increase. Okay? The downside of SIBO is if you have somebody who's bradycardic and you start SIBO, you're going to make them more bradycardic. So this is not the right agent to use in somebody who's severely bradycardic. See, this is the benefit of knowing these drugs, because then you say, okay, which one do I choose? And as a student, when you get to clinical, I'm going to watch you after you get intubated. And the first thing you do after you get intubated, I had one student do this. After they intubated, I looked at her like, wow, you're really happy with yourself. And she goes, yeah, the first one I've had. I said, only one problem. She goes, what? You need to ventilate the patient. Get back to duty. Okay. But she was all excited. But then she looked at me and she said, what do you want me to start? And well, that's part of your decision making. You have to start deciding on the first date what agent you should use. At least you should be able to argue scientifically why I want to use that agent. It was appropriate that she asked me that, but what she should have said was, I want to start this agent. And this is why. And then she gave me all the reasons. And then I would say to her, well, that's a good consideration, but you might consider this. Okay, and then I would possibly argue back and forth. And that's how you want to do it. And then you got to hear both sides of it, and then you decide, well, which one should I use? And you turn it on. SIBO would be a good indication not to use it, would be somebody who's bradycardic. I would use desferrine more than that individual, or use isoforine, because those immediately increase heart rate, versus SIBO would make you more brady, at least initially. There's some concern at times because it can cause prolongation of the QT interval, but nobody's been found to go into malignant VTAC or anything with SIBO. So that's a theoretical concern. And patients that have long Levine syndromes and QT syndromes have never been contraindicated with SIBO, so I don't see that as really much an issue. It is more something that the book discussed, and that's where I want to throw it out at you. Central nervous system, there's a slight increase in cerebral blood flow in ICP, but it does decrease the metabolic rate of oxygen consumption. So in that sense, it's actually very easy. You can use SIBO in neurological cases without any problem. You slightly hyperventilate the individual, it overcomes the effect, so it's a good agent to use. I still use forine because it's been found to be cerebrally protective, so that's my agent of choice still. Contraindications, so MH, hypovolemia, and elevated ICP is a precaution more so than anything else. SIBO is unfortunately vulnerable to metabolism. You can get 3 to 5% biodegradation of this compound to inorganic fluoride and to what's called hexafluoroisopropanol, propanol, It cannot form acyl halide, so it's not hepatotoxic, but it does form carbon monoxide as well as form compound A. When you form, and it doesn't matter if it's dry or wet, if you use a strong base plus sevoflurane, it forms compound A, which is fluoromethyl 2,2-difluoro-1-trifluoromethyl vinyl ether. Woo, okay. Just call it compound A, okay? Nobody's going to ask you to memorize the chemical compound, but I just wanted to show you that it does exist. This is what compound A actually looks like, and what compound A basically is it takes and breaks down one of the fluoride bonds, flips it, makes it a double bond like here, and that's your actual compound A. And that's actually it's actually kidney toxic. Okay. So how do you minimize it? To minimize exposure of compound A, sevoflurane should not exceed 2 Mach hours at flow rates of less than 1 to 2 liters per minute. And that's why the FDA still recommends the fresh gas flows of less than 1 liter is not recommended. Now, in 1997, Beto showed that low flow is still safe. Okay, what he did was he took the compound and he then exposed this individual, and then they checked things like albuminuria, which is albumin in the urine, which means that the kidney tubule is now leaking proteins. Glycosuria, enzymuria appear to be associated with inhalational doses of compound A exceeding 160 parts per million per hour. Beto et al., when he did his study, when he used the compound, he combined it with nitrous oxide. So what did that do to this compound A production? It went way down because his MAC value went down per hour. That's what people don't understand. So if you combine SIBO with nitrous together, you're really not producing enough SIBO compound A to be a problem, which is a turning point. So you can go to low flows as long as you're using nitrous oxide. If you're using low flow with only SIBO, you're asking for it. Now you're in trouble. So Beto is great if you're using it combined with nitrous oxide. This is a very beautiful study, really well done. It shows you right where the number is at. You see, everybody's fine until you get beyond 168 parts per million of compound A production, which can happen. And so what's a real solution to it? My real solution is change your absorber. The widespread application of absorbers that minimally degrade SIBO or desflurane or isoflurane to carbon monoxide will eliminate any potential hazard from these toxic compounds. And so it's worth the extra cost. So you need to consider asking what kind of bare lime you have. The bare lime does not contain either sodium hydroxide, potassium hydroxide, both of which appear to enhance production of compound A and carbon monoxide. Instead, you can buy things called calcium hydroxide or lithium hydroxide. Calcium hydroxide is actually made by a company in Northern Ireland, and lithium hydroxide is made by the Dornier company in Germany. Okay? I don't know if you know anything about World War II history. Dornier, the ones that actually produced the bombers for the German military. Dornier also became a medical company after the war, and they actually produced our lithotripters. Okay, that's the first lithotripter was the Dornier lithotripter. So now they're producing lithium hydroxide for us. If you use those agents, then you have no production at all of compound A. So why not go to that, spend the extra cost, and now you can run your SIBO at low flows all the time with no worry. That's the way to go. That way you can save a lot of money. The offset of the cost of the bare lime will be offset by the loss of using the actual agent. So that's the real solution. We'll stop there, and we'll start up on xenogas next week. Thank you.